In this regard, I like to thank Eskayef Pharmaceuticals for inviting me as a speaker. And today my topic is detecting the undetected MASLD Burden Evidence-Based Evaluation. So I will limit my talk regarding the evaluation of MASLD. And in my today's talk, I like to highlight few things regarding the definition, the nomenclature, the evolution of the name MASLD, the cardiometabolic risk factors, epidemiology, reasons for underdiagnosis, some non-invasive diagnostic tool, and some primary care setting recommendation and how to prevent this MASLD. And in my today's talk, I like to acknowledge these two guidelines from where I prepared my talk, the Asian Pacific Association for Study of the Liver Clinical Practice Guideline and European Association of Study of Liver Disease, EASD, ESO Clinical Practice Guideline. So first start with what is MASLD, or Metabolic Dysfunction Associated Steatotic Liver Disease, how the name came, how the evaluation occurred. First, the NFLD was the first detected or designated as the accumulation of fat in the liver except the alcoholic cause. So first the liver disease was identified as the accumulation of liver fat without significant alcohol consumption, and it is characterized by hepatic steatosis identified through imaging and histology in the absence of secondary other causes of fat accumulation. Next, in 2020, the first idea of metabolic associated fatty liver disease was thought, and it is known that it is related to metabolic dysfunction. The fatty liver disease is metabolic dysfunction with obesity, type 2 diabetes, hypertension, dyslipidemia, and different features of insulin resistance. And it also includes individuals with moderate or any amount of alcohol intake. So alcoholism in conjunction with the other cardiometabolic risk factors is designated of metabolic associated fatty liver disease. In 2023, finally, the name was established or designated as MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease. And actually, it is a steatotic liver disease in individual with at least one cardiometabolic risk factor and without any harmful alcohol consumption. So the nomenclature is like this: MASLD. These three names is still should be discussed in these three options. The MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease, previously which was named as NFLD. The MASH, actually it is the histological diagnosis, the metabolic dysfunction associated steatohepatitis, which is characterized by the histological features of hepatocellular, ballooning, and lobular inflammation, that is diagnosed by liver biopsy. And SLD, the steatotic liver disease, these encompasses all the liver diseases: MASLD, metabolic associated alcoholic liver disease, alcohol-related liver disease, that is ALD, other specific types of steatotic liver disease including drug-induced and monogenic diseases, and also the cryptogenic steatotic liver disease. So all these liver diseases are included under the heading of SLD. So now this is the simple form of the steatotic liver disease, where steatotic liver disease includes the hepatic steatosis in any form, and there may be, then we should look for the, if any imaging we find the steatosis or hepatic fatty infiltration, then we should search for the cardiometabolic risk factor. If there is cardiometabolic risk factor, then we should take the diagnosis as MASLD. And if there is no metabolic risk factor, then we should think about the alcohol consumption or other cryptogenic or drug-induced advices, classifications. So MFLD, there should be hepatic steatosis, overweight or obesity, metabolic abnormalities, and type 2 diabetes, any one of the cardiometabolic risk factor plus hepatic steatosis. So what are the cardiometabolic risk factor for diagnosis of MFLD? This is actually recommended or designated by the guideline. The metabolic cutoff that should be present any one factor along with the hepatic steatosis will designate a person as a MASLD is overweight or obesity either by high BMI or waist circumference beyond the target. That is BMI more than 23 kg per meter square, waist circumference more than 90 centimeter for men and more than 80 centimeter in women. Dysglycemia in any form, in the form of IGT, IFG or diabetes, or patient on treatment of diabetes mellitus. The two components of lipid profile, the plasma triglyceride and HDL, should be plasma triglyceride more than 150 milligram per deciliter, and HDL less than that cutoff value according to the gender, and the blood pressure more than 130 by 85 millimeter mercury. Next, the cardiometabolic risk factors actually influences the occurrence of MASLD and its complication in different way, because the relative impact of different cardiometabolic factor is different. Suppose the obesity and overweight, this is the most important determinants of the risk of complications of MASLD, including cirrhosis, hepatocellular carcinoma, and hepatocellular related mortality. So compensated cirrhosis among the obese patient is have a more dreadful complication than that of the non-obese MASLD patients. Next, the hypertension and dyslipidemia. There is a 1.8-fold higher risk of progression to cirrhosis or hepatocellular carcinoma among patients with hypertension and dyslipidemia. Regarding type 2 diabetes, this is actually determinant of the risk factor for cirrhosis, hepatocellular carcinoma, and its related mortality, and associated with poor outcome in individual with poor glycemic control. And the biopsy-proven MASH patients and compensated cirrhosis, including a 4-fold increase in the risk of death in diabetic patients than that of the non-diabetic. So these 3 factors are most important cardiometabolic factors for progression and complication of MASLD. There are some other metabolic factors also, metabolic parameters also, obstructive sleep apnea and polycystic ovary syndrome. They are associated with MASLD, and several studies suggest that OSA also associated with more advanced MASLD or MASH features. Next, the menopausal status is also associated with approximately 2.4-fold higher odds for MASLD disease, and women aged more than 50 years have an increased chance of developing MASLD and its related complications. Smoking and alcoholism, of course, been associated with increased risk of hepatocellular carcinoma as well as MASLD specifically. So this is the spectrum of MASLD. Starting from a healthy liver, there is an increase in chance of deposition of fat as there is presence of the cardiometabolic risk factors and other factors. There is an increased chance of 15 to 30% to conversion to the steatosis in liver. And actually the normal fat content is less than 5% in the liver. Total healthy liver contains less than 5% of the fat. When there is steatosis or MASH or MASLD in the early stage, there is approximately more than 15% of the fat that is present, or more than 5 to 10% fat is deposited. Then it is diagnosed as simple steatosis. After the gradual progression of the disease, make it MASH, when there is an increase in the deposition of the fat in the liver, and later on this progresses to cirrhosis and cirrhosis-related comorbidities. And several factors except the cardiometabolic factors are also involved in this progression of the spectrum of MASLD. Next, what about the prevalence of MASLD? The global prevalence is 25% in 2016, and alarmingly, it is more than 30% in 2020 study. Approximately 10 to 30% persons with isolated steatosis progresses to steatohepatitis and advanced liver disease, but the risk is much higher in patients with type 2 diabetes. That is 40 to 65%. So type 2 diabetes is an individual factor for presence. It complicates the MASLD situation. Males and females more than 50 years, postmenopausal women, and individuals with multiple cardiometabolic risk factors are increased risk for progressive disease. So the prevalence of MFLD in Asia-Pacific region ranges from 28 to 40%. And a recent meta-analysis showed that the Southeast Asian region, the prevalence of MSLD is 33%, which is published in 2025. What about Bangladesh situation? It's my pleasure to share a paper which is published by one of our guests, and also our panel of experts is the study panelist here. The prevalence and risk factor of non-alcoholic fatty liver disease in Bangladesh, which is published in 2018. A total 2,782 participants were included in the study, and the prevalence was 33.86%. It is 5 years back study, but gradually it is progressive, and nowadays probably it will be much higher than this projected here. And the factors that is contributing to the progression of MSLD, which is evident from this study, is increasing age, presence of diabetes, high BMI, and significantly associated with NFLD. And at that moment, the designation was NFLD. That's why it is written in the study result. Another study, which is published in 2020, the prevalence, risk factor, and metabolic profile in non-obese liver disease patient in South Asia, where the door-to-door survey was done with several clinical, anthropometrical, biochemical results along with ultrasonogram, with a huge number of patients, showing an 18.5% participant having the fatty liver disease in a rural community. And the metabolic profile of non-obese NFLD is very much different than that of the obese person. So obesity not only the risk factor, non-obese lean patients may also have increased chance of complication and presence of NMFLD in rural setting also. Not only in the rural and urban, but there is some variation in the adolescent and adult, that is the adult and the pediatric group of patients, as we are very much aware about the childhood obesity and gradually increase in the childhood obesity globally and in Bangladesh also. So I like to show few differences in the MASLD situation in adult versus pediatric population. First, the risk factors. Along with the adult risk factors, in the pediatric group, there is a family history and genetic predisposition of MASLD among the family. And the disease progression, though the disease progression in the pediatric population is less well defined, but potential for early fibrosis development is very much high in pediatric group as they develop this complication from the very early age. The comorbidity along with the regular comorbidities, obesity, insulin resistance, dysglycemia, dyslipidemia, and polycystic ovary syndrome are the comorbidities present in this pediatric population. And the long-term outcome is the potentiality for pediatric patients have the persistence of the liver disease, metabolic syndrome, and the cardiovascular disease is very much complicate the pediatric population as similar that of the adult population. And the management actually the lifestyle modification and the family-based education is very much important in the pediatric population, as study of these MASLD drugs is not so much done in the pediatric population. So lifestyle modification and education play an important role in the pediatric population. Now the question is, why MASLD remains underdetected? Because the liver disease may remain asymptomatic and silent in progression. Actually, the incidental detection of fatty liver disease in ultrasonogram is very much common. The primary care level, the screening is not so much done, and the disease awareness is not so much common in nowadays, and normal liver enzyme actually do not exclude the significant disease or significant presence of MASLD. For this reason, it remains underdetected, and the guideline emphasis given for proactive case finding and screening in the high-risk group. So how to screen? That is very important, because we should consider the case finding strategies for liver fibrosis and the liver steatosis from the very early period, not only with the biochemical parameters, but along with that the non-invasive tools also. And also the search for the cardiometabolic risk factors, type 2 diabetes, abdominal obesity, metabolic risk factors, and abnormal liver function test. And this benefit of this early screening is to early scope of intervention, early referral to hepatologist, and prevention and progression of cirrhosis and hepatocellular carcinoma. Next, the diagnostic pathway, how to screen, how to progress for stepwise approach for detection and diagnosis of MASLD. The first thing is the clinical risk assessment and laboratory values, including the lipid profile, blood glucose level, and liver enzymes. Step 2 is the non-invasive fibrosis score, then the imaging and the specialist referral. The non-invasive tools, what are the non-invasive tools in practice and at our hand? First, the FIB-4 index, that is the non-invasive, inexpensive first-line test may be done even with a simple app in our hand also. Next, the ultrasonogram, which causes the steatosis detection, fibroscan, fibrosis stratification, and enhanced liver fibrosis test. So let's come one by one along with the FIB-4 index. That is a formula given here for the FIB-4 index, the fibrosis 4 index, which is calculated by age, AST, platelet count, ALT, should be taken into account, and we can easily calculate it as FIB-4 score. And in the mobile app, this is the app presentation, and this will come and we put the data here and we can calculate the FIB-4 score. So what to do with this FIB-4 score and how to classify the disease if you look at this, if the patient has type 2 diabetes, obesity, cardiometabolic risk factors, and persistently elevated liver enzyme, we calculate the FIB-4 score, and the cutoff is less than 1.3, 1.3 to 2.6, 2.67, and more than 2.67. If it is less than 1.3, then 1 to 3 hour yearly follow-up is indicated. If it is more than 2.57, immediate referral to the corresponding hepatology referral is very much important. And if it is in between these two cutoff, 1.3 to 2.67, then we should look for the other additional comorbidities. And also the elastography is very much important test for this situation when their FIB-4 score is 1.3 to 2.67. One important thing is that this is applicable, this cutoff is applicable for age less than 65 years. When the age is more than 65 years, then the cutoff will be different, keeping the lower value to 3. Next, the fibroscan, that is very much important test nowadays, and we all are very much used to do a fibroscan. And the two things that is seen in this fibroscan report is the liver stiffness measurement, LSM, that is the presence of fibrosis scarring, and the normal is 2 to 7 kPa, and that is F0 or F1 stage. A moderate fibrosis F2, 7 to 11 kPa, severe fibrosis F3, 11 to 14 kPa, and cirrhosis if it is more than 14 kilopascal. Another thing is the controlled attenuation parameter, CAP. The CAP value measured by decibel per meter, and it typically ranges from 100 to 400 decibel, and the lower value actually indicates less fat. So the lower the value, that is will be more good in interpretation of this result. Next, the imaging, the ultrasonogram and magnetic resonance elastography, and special ultrasound devices is required, and it is nowadays very much used to, and each and every ultrasonogram report we see the fatty liver grade 1 like this. But we should be very much judicious in screening by ultrasound, and the devices should be enabled for this measurement of the fat and then designation as a fatty liver disease. Next, the important test is vibration control transient elastography. That is very much important, and to see the exact level of the fatty stage and the steatosis and the fibrosis stage, liver stiffness measurement and control attenuation parameter can be measured by this way. And the MR elastography, where available, is a very much helpful tool for assessment of liver stiffness and fibrosis staging. MRI, in situation when these investigations are not available, can be a tool for quantitative assessment of liver lipid content, for grading the liver steatosis, monitoring the effects of intervention, and also the triglyceride content. That is very much important for MRI, actually can detect this triglyceride content in the liver, and the non-invasive gold standard test for hepatic lipid quantification. Next, what to do in the primary care level, actually how to find the case and how to implement the strategies. As there is an integrate risk scores into routine diabetic and obesity clinic, we should look for this MASLD. Education for the primary care providers for the MASLD, how to screen, how to assess, how to investigate, and when to refer is very much mandatory, and standardization referral pathway is very much important in managing these MASLD cases, and health system adoption for guideline algorithms for individual races and ethnicity is very much important nowadays. So from diagnosis, evaluation and monitoring, the patients who are at high risk population for MASLD, that is having the cardiometabolic risk factors, hepatic steatosis should be assessed, and if any factors, any cardiometabolic factor is there, then we should look or search for MASLD. If there is 2 or more cardiometabolic risk factor, we should think about presence of MFLD or MASLD. If the patients having no baseline evidence or fibrosis, or we can follow up the patients 2 to 3 yearly, and evidence of significant, if fibrosis is there, then monitoring should be done annually, and if the evidence of cirrhosis is there, of course should be managed by respective specialist, and monitoring should be done according to the patient's situation. Next, the one important thing is the liver biopsy. We cannot rule out or forget the liver biopsy, though this is an invasive test, and there are some indications of liver biopsy, that is actually when the diagnosis is uncertain and there is a need for evaluation for dual pathologies, alcoholic, fatty liver disease, cardiometabolic, or MASLD. When non-invasive test is inconclusive or make confusion about the diagnosis, discordant, and risk stratification based on the non-invasive test alone is inadequate, in that case liver biopsy can be done, and in some research protocol, if it is required to do the liver biopsy, then it can be done. Though the next speaker will highlight regarding the management, but I just kept one slide for lifestyle modification that is very much important for control and prevent the progression of MASLD. That is the weight loss by dietary changes, physical exercise, and optimal management of comorbidities, because both these factors, the cardiometabolic risk factors and the MASLD, influences each other for their progression. So proper management of diabetes, hypertension, and dyslipidemia is very much mandatory. We will hear from Dr. Saifuddin about the management, but one thing I like to add here regarding the diabetes management, GLP-1 receptor agonist or SGLT2 inhibitor have promising role in management of diabetes and weight reduction and fatty liver improvement. For dyslipidemia, statins should be used, and obesity, we should go for even bariatric surgery also. And regarding the MASLD, the newer drug, the resmetirom, has promising effect, and we should go for this according judicious use of this medication when indicated. Few points regarding prevention. That is the most important thing for prevention of complication regarding the liver disease is the lifestyle modification. Maintaining a healthy weight, following a balanced diet, and physical activity should be maintained for prevention of this MASLD. So which patients are at higher risk for hepatocellular carcinoma? Presence and duration of type 2 diabetes, obesity, or both, older age, concurrent alcohol intake, and individual having a FIB-4 score more than 3.25, individuals with LSM score more than 10 kilopascal, and increasing change in LSM over time. That is very much important point for follow-up to keep in mind for see the progression of MASLD. Next, in my last two slides, I like to highlight few points regarding the future work, how we can work with this MASLD, because all individuals of MASLD or general population have the choice of non-invasive tests to be done in their routine follow-up, even in the obesity clinic and the diabetes clinic. And the target population and the best tools for hepatocellular carcinoma surveillance should be available at the primary care level also. And this development in MASLD individuals without cirrhosis is even possible to develop HCC or hepatocellular carcinoma. So it should be always kept in mind. And provision of extended period of phase 3 or 4, that is a post-marketing trial, and the real world studies is possible as this resmetirom is available in our country now. And it will be actually not be ideal to conclude my talk without highlighting a few points regarding the AI, the artificial intelligence in use in treatment of MFLD or MASLD. Actually, it is now available in each and every section of medicine management. In that regard also, MASLD AI can help us in precision of the management or investigation of the non-invasive tool and missing the misdiagnosis or underdetermined MASLD cases. And also there is a very close in the non-invasive tool also, and also in the FIB-4 score and the ultrasonography, the F0, F1 and the F2 gradings are very much close together and is also manual dependent. In that case, AI also help us in designating the levels of MASLD. So I like to conclude my talk with that MASLD is very common, metabolic driven, and of course detected or underrated. It should be properly screened. Provision of diagnostic, screening and management framework should be there in the population level, at the primary care level, and non-invasive tools are very much handy and available for identification, and multidisciplinary team approach is the most important thing in managing and diagnosing MASLD. And patient-centered multidisciplinary management method focusing the liver damage, treating metabolic dysfunction, and prioritizing the patient-reported outcome is necessary. Thank you for your patience hearing.